I spent 23 years standing over operating tables, and I can tell you the moment that changed the way I practice medicine forever. It wasn't a dramatic moment. There was no crisis, no emergency. It was a Tuesday afternoon. A 74-year-old woman named Margaret sat across from me in my office, folding and unfolding a piece of paper in her lap. The paper was a consent form. Her cardiologist had referred her for bypass surgery. Her primary care physician had co-signed a recommendation, and the scheduler had already blocked out an operating room slot 3 weeks away. She looked up at me and asked one question. She said, "Doctor, is there anything else we can try first?" I paused, and in that pause, I realized I hadn't been asked that question in a very long time. Patients came in, reviewed the risks, signed the forms, and trusted the system. Margaret didn't distrust the system. She just wanted to understand it before she handed her body over to it. That question sent me back to her full file. Her kidney numbers, her frailty indicators, her medication history, and what I found changed my recommendation entirely. Margaret was not the average surgical candidate. She was someone whose body, if we were being honest with ourselves, would spend far more energy surviving the operation than recovering from it. We pursued an alternative path. 14 months later, she was gardening again. I tell you that story not to undermine surgery. Surgery is extraordinary. It has saved more lives than perhaps any other medical intervention in human history, and I have been privileged to be part of that. But over 2 decades in the operating room, I have also seen something that medical professionals do not discuss loudly enough. The older the patient, the more the body's relationship with surgery changes. Not just statistically, biologically, fundamentally. Here is something most people don't fully understand about what happens inside the body when it goes under general anesthesia. The heart works harder. The lungs take longer to clear the medication from their tissue. The kidneys slow down considerably in how they process drugs. And the brain, perhaps most surprisingly, enters a state of disorientation that in patients over 70 can persist not for hours, but for weeks, sometimes months. Physicians have a clinical term for it: postoperative cognitive dysfunction. It is more common than any hospital brochure will tell you, and it is one of the most distressing things a family can witness in someone they love. None of this means surgery is the wrong choice. What it means is that for a person over 60, the surgical conversation must go deeper than it usually does. Think of it this way. If you take 2 vehicles, one fresh off the production line and one that has traveled 200,000 miles through every kind of weather, and you subject both to the same mechanical stress test, you do not expect the same result. You account for wear. You account for resilience. You account for recovery time. Medicine, for many decades, failed to make that distinction clearly enough. The same protocols that serve a 45-year-old were applied to a 78-year-old with 3 underlying conditions. That is changing, but not quickly enough and not consistently enough across every hospital in every city. There is a word that has become central to how I evaluate older surgical candidates, and that word is frailty. Not age. Frailty. These are not the same thing. Frailty is a clinical measurement. It means the body's functional reserve, its capacity to absorb stress and recover from it, has dropped below a threshold that matters enormously in surgical outcomes. Approximately 40% of adults over 75 show signs of clinical frailty. By age 85, that number approaches 60%. A frail 70-year-old faces dramatically different surgical odds than a vigorous 82-year-old who walks 3 miles a day and sleeps well. The number on the birth certificate is almost beside the point. So let's talk about the surgeries where this distinction becomes most critical. Open heart surgery is one of the most commonly recommended major procedures for older adults. When coronary arteries become blocked, rerouting blood flow through bypass grafting can be genuinely life-saving. And for the right patient, it is a remarkable intervention. But the procedure as traditionally performed requires stopping the heart completely. A bypass machine takes over the work of both the heart and lungs while the surgeon operates. For a healthy 62-year-old, that is a manageable assault on the body. For a 79-year-old with reduced kidney function, early cognitive changes, and insulin-dependent diabetes, That same bypass machine is not just stressful, it is simultaneously traumatic to nearly every major organ system at once. The research is sobering. In frail elderly patients, open-heart surgery carries a 30 to 40% risk of serious complications. Stroke, kidney failure, prolonged mechanical ventilation, extended and severe confusion. And in the highest risk populations, up to 15% of patients do not survive 30 days past the operation date. Not from their underlying heart condition, from the surgery itself. What has changed the landscape dramatically is a procedure called transcatheter valve intervention, a catheter-based approach that never requires opening the chest or stopping the heart. It is less visually dramatic than open surgery. It does not look like the medical heroism people imagine. But for a body that has lived 7 or 8 decades and needs a gentler hand, gentleness is not weakness, it is wisdom. The question worth asking any cardiologist or cardiac surgeon is a simple one. Is a catheter-based approach an option for my specific situation? That single question has, for many patients, completely redirected the conversation toward a safer road. Spinal surgery is the second area where I see older patients consistently underinformed. Back pain after 60 is nearly universal. Very few patients I've spoken with over 70 have not mentioned their spine in some form. And the surgical solutions being offered, multi-level fusions, extensive hardware placements, complex decompressions, have increased substantially in both frequency and scope over the past 15 years. Some spinal surgery is urgent and undeniable. If the spinal cord is being actively compressed, if someone is losing bladder control or facing paralysis, operating is not optional. That conversation is short and it ends in the operating room. But elective spinal fusion for chronic degenerative pain in an elderly patient is a different story entirely. A major published analysis found that in patients over 65, complex spinal fusion carried complication rates exceeding 40%. These were not minor complications. Blood clots, deep infections, hardware failure, and a phenomenon called adjacent segment disease, where the vertebrae neighboring a rigid fusion begin to deteriorate because the mechanics of the spine have been permanently altered. You stabilize one level, and the levels above and below absorb the punishment. What makes this harder is that the promised benefit, lasting pain relief, is often not delivered. Multiple large studies have found no statistically significant difference in long-term pain outcomes between aggressive spinal fusion and a well-designed program of physical therapy, anti-inflammatory treatment, and targeted nerve block injections. The conservative route carries a fraction of the risk and frequently delivers the same or better quality of life over time. A mentor of mine once said something I have never forgotten. He told me that in his experience, the most technically difficult surgical decision is sometimes the decision not to operate. I return to that idea often. Major cancer surgery occupies a profoundly different emotional space. When a patient hears the word cancer, every instinct says remove it, eliminate it, fight it with everything available. I understand that instinct completely. It is human and it is reasonable. But 2 decades of watching outcomes has taught me something important. The goal of any cancer treatment is not simply to remove the tumor. The goal is to give that specific person more good years of meaningful life. Those 2 objectives are not always achieved by the same path. The Whipple procedure, used for pancreatic cancer, is among the most technically demanding operations in modern surgery. It involves removing substantial portions of multiple organs and takes between 6 and 10 hours to complete. In younger patients with robust health, it can be genuinely curative. But in an 81-year-old with cardiovascular disease and impaired kidney function, the surgery may succeed in the technical sense. The tumor may be fully removed, and the patient may still not survive the following month. Not because the cancer killed them, because the body could not absorb what the operation required of it. This is called futile surgery in medical literature, and it is far more common than most patients or families ever learn. A major study from the American College of Surgeons documented that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers call failure to rescue, a situation where a complication arose that the body lacked the reserves to survive. The conversation worth demanding from any oncologist is this: if we choose not to operate, what does a non-surgical treatment pathway look like for someone with my exact health profile? Radiation, targeted therapy, immunotherapy, watchful waiting with palliative support. These are not surrender. In many documented cases, they have provided better outcomes in terms of both survival and quality of life than surgery would have. Joint replacement surgery, particularly hip and knee, represents one of modern medicine's genuine success stories. For appropriate candidates, these procedures transform lives in the most literal sense. People who could barely walk to the kitchen are hiking trails 18 months later. The results, for the right patient, are extraordinary. But the word elective carries tremendous weight that is often overlooked. Elective means planned. It means there is time. And time is the most valuable resource in surgical preparation because it means there is an opportunity to assess whether the body is in the best possible condition before it faces that level of stress. In patients over 75 carrying 3 or more serious conditions simultaneously, heart disease, poorly controlled diabetes, chronic kidney impairment, significant obesity, elective joint replacement carries meaningfully elevated risk profiles. Blood clots forming in the deep veins of the legs are the most serious concern. A clot that travels to the lungs becomes a pulmonary embolism, and in patients with already compromised circulation, that event can be fatal. Add the risk of post-operative pneumonia from limited mobility during recovery. Add hospital-acquired infection. The picture becomes significantly more complicated than the standard informational brochure communicates. The intervention that has changed outcomes most dramatically in this area is called prehabilitation. Structured physical conditioning, nutritional optimization, careful management of blood pressure and blood sugar, all undertaken in the weeks or months before surgery. Hospitals that require prehabilitation programs for high-risk elderly patients before scheduling elective joint replacements consistently report lower complication rates, shorter hospital stays, and faster functional recovery. If a surgeon has never discussed prehabilitation with you ahead of a planned procedure, that word alone is worth introducing into the conversation. Emergency abdominal surgery stands apart from every other category because it removes the luxury of time and choice. A bowel perforation, a ruptured vessel, severe internal bleeding, these do not wait for morning appointments or second opinions. But here is why this subject belongs in any serious conversation about surgical risk in older adults. Understanding the odds in advance changes how families make decisions in the middle of a crisis, when panic is high and clarity is difficult. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in the surgical field. In the most severe presentations, those numbers range from 30 to 50%. This is not a reflection of surgical skill or hospital quality. It reflects what happens when an older body is subjected to sudden, overwhelming trauma simultaneously across multiple organ systems. The inflammatory response that a younger body resolves in days can spiral in an older body into systemic collapse, with organ systems failing in sequence. Two things follow from this. First, abdominal symptoms in older adults deserve prompt, serious medical attention. Persistent pain, unexplained bloating, meaningful changes in bowel habits. These are not things to monitor quietly for 6 months. Catching the underlying problem before it becomes an emergency is the most powerful intervention available, and it costs nothing but attention. Second, and perhaps most importantly, the conversation about surgical wishes should happen at the kitchen table, not in a hospital corridor at 2 in the morning. What matters to you in terms of quality of life? How do you feel about aggressive intervention if the odds are difficult? These are not morbid questions. They are among the most loving conversations a family can have because they remove the weight of impossible guessing from the people who love you most. There are 4 questions every patient over 60 should carry into any major surgical consultation. What happens to my condition if I choose not to have this surgery right now? A surgeon who answers honestly will tell you whether the timeline is urgent or whether time is genuinely available. Is there a less invasive alternative available for my specific case? Medicine has changed profoundly in 15 years, and options that did not exist when many surgical protocols were written are now widely available. What does realistic recovery look like for someone with my particular health history? Not the average patient, but me. And finally, what is your personal complication and outcome rate for this procedure in patients over 70? Surgeons track this data. The ones who answer that question directly and without defensiveness are the ones whose hands you want. The landscape of medicine available to older patients right now is genuinely extraordinary. Laparoscopic and robotic-assisted techniques have reduced the physical trauma of many procedures to a fraction of what open surgery once required. Catheter-based interventions have created pathways for patients who would never have survived the traditional approach. And optimized medical management, the right combination of targeted medications, structured physical therapy, and nutritional support has proven itself capable of managing conditions that once seemed to have no path forward without surgery. The body is a resilient and intelligent system. It wants to heal. Sometimes the most important thing a surgeon can offer is not a procedure. It is a clear-eyed, honest assessment of what the body actually needs and the willingness to say when the most powerful medicine available is time, preparation, and a better-informed choice. A surgical recommendation is not a verdict. It is the opening of a conversation, and you're not a passenger in that conversation. You are the person at the center of it. Ask the hard questions. Request the alternatives. Take the time that is available to you. Seek a second opinion, and if necessary, a third, without apology. The surgeon holds the instruments. You hold the decision, and that decision, made with full information, clear eyes, and a complete understanding of your own body and values, is the most powerful force in your medical care. More powerful than any technology in the operating room. Take that power seriously. Use it without hesitation. You have earned it.